It's really my absolute pleasure to welcome Dr. Kim Eagle this morning. I've had the pleasure of working with him as a mentor, colleague, and friend for 20 years through our IRAD organization. But I want to thank Josh Buckler for suggesting that we bring him here today. Kim is the Albion Walter Hewlett Professor of Internal Medicine, Director of the Frankel Cardiovascular Center at the University of Michigan. He's a graduate of Oregon State University, Tufts University School of Medicine. He did his residency at Yale New Haven and then did fellowships in cardiology at Harvard Medical School and Mass General Hospital. From 1986 to 94, he was the Associate Director of Clinical Cardiology at MGH and Associate Professor of Medicine at Harvard before leaving for Michigan. At Michigan, Dr. Eagle has led major outcomes research and quality improvement programs in cardiovascular care and public health. He founded Project Healthy Schools to combat childhood obesity, which is in over 100 elementary schools throughout Michigan. He's also involved with Project My Heart, Your Heart to recycle cardiac pacemakers. He's delivered presentations to over 115,000 learners and published more than 780 manuscripts. He has leadership roles within the ACC, NHLBI, Marfan Foundation, and of course, IRAD. And those are just a few highlights from his CV, which is almost 90 pages long without any abstracts. My favorite Dr. Eagle thing right now is this weekly podcast, which is a concise summary of the research highlights from meetings and from journal articles. He's also a huge Michigan sports fan. He co-authored the book Heart of a Champion with Bo Schembechler. And beyond medicine, he also is a passionate supporter of the arts, an avid fly fisherman, a skier, and a devoted member of the Ann Arbor community. Kim, thanks so much.
Thank you very much for inviting me. Can you hear me okay? Everything's fine? Yeah. I have great respect for this institution. You know, I think what you've done for heart attack care and how you've created that network, and now with Kevin and other faculty, the Aortic Dissection Network are the best of their kind. And the type of care you deliver and the passion you have for it is known throughout this country and abroad too. So it's really a privilege for me to be here. And we've worked together for 20 years on our aortic dissection program. So it's doubly delightful for me to have a chance to talk to you about that. I've been way too ambitious with my slides today. So what I'm going to suggest is that if you want my slides, just email me, keagle@umich, and I'll send them to you, because I'm going to skip over some. This really is an hour talk, and I'm going to cut it down to about 45 minutes, okay? So here we go. These are my disclosures. I guess the point of this slide would be, when I talk about endovascular therapy, you should understand that the dissection registry has received support from companies like Gore and Medtronic. They make those devices. So you have to filter my thoughts about that with that in mind. So we're going to talk about the epidemiology, how we classify this disorder, how patients present, how we image them, and treatment. But I really hope we have more time to talk about the future. And the future is now in some of these areas, and I think it's important. And we have a patient who presents with a clinical scenario and a physical and an EKG, and they may have predisposing conditions. And they all get sort of put into this strategy of care. If they're type A, they get operated. If they're not, they may get operated. If they're complicated, type B. And then we put them into a sort of a pathway of what we're going to do long term. That includes medications, imaging cadence, things like that. And I would argue that that is really cookbook medicine, and the future for us is much more personalized. We need to do a much better job of saying, if he's had a dissection, what do I know about his risk going forward, and how do I properly monitor that risk and mitigate it? And I don't think we do a good job on that. The epidemiology of dissection is hard to judge because many patients die at home. This is a population study done from the UK. And most patients who dissect either have a heritable condition or they have uncontrolled hypertension. It is very common. 50% of these patients died at home. Obviously, if they have a chance to get to you, they have a good shot at survival, over 80 to 90%. Familiar faces that we've lost with dissection, John Ritter, this wonderful Grant Wall at the World Cup. This is a disease that afflicts all of us. Thankfully, it's rare, but it's really a big problem. The term acute aortic syndrome encompasses more than just classic dissection, and I show that on this slide. The lion's share is a classic tear in the aortic intima, but we see intramural hematomas that Dr. Harris has published on. There's something called penetrating aortic ulcer. I won't talk about that today, but it afflicts primarily elderly people with atherosclerosis, often in the distal aorta. And there's this new term recently, discrete aortic dissection, which is just a tiny little tear shown down here. So there's a tiny interruption, and this may simply be something that's a harbinger for classic dissection later. I'm going to predominantly talk about classic dissection here, where you have a tear in the intima, and there's propagating hematoma that separates the two lumens. And, in terms of classification, I like to think simple. And for me, this is simple: Stanford A, Stanford B. And ironically, despite all of the nuances of classification that have been designed in the last 10 years, this still ends up being, for a cardiologist, what matters. Is the ascending aorta involved? And how close is it to the aortic valve? Okay? And of course, you see in this slide that the arch is in no man's land, or no woman's land. And the studies that we've done suggest that the more proximal the dissection, the more dangerous it is for immediate mortality. But there's a lot of nuance in classification. This is from the Society of Vascular Surgery, where you basically look at where the site of origin was and where it finishes up. And you see an A5 to the left. A B310 means zone 3 was the tear, and zone 10 was where the tear finished up. And for surgeons, and this is very important, for cardiologists, Kim Eagle, no, it's a type A or type B. And if it's a B, is it complicated? That's about it. I'm simple. And if it's an A, we're going to operate quickly. And you can go to the TEM classification, which is nuance, the type on the top, and then the entry site, and then whether there's malperfusion or not. And I think over time, if we develop large registries in nations, this type of granularity will be quite helpful in terms of looking at downstream risk and mortality. But for the moment, for me, it's not. This is an amazing slide that really caught my attention. 1958, I was 5 years old. And this is a look at outcome for patients with an aortic dissection. And they on the y-axis, they just said % dead. That's pretty abrupt. And it shows you actually that if you live about 14 days, that curve starts to level off a little bit. Isn't that interesting? This is Darwinian with dissection. If you can live 14 days with a dissection, you might live, You got to be tough to do that. And so I like this classification that Kevin and others in our IRAD registry created. And if you look at the top panel, type A dissection from symptom onset, if you're not operated, you have a mortality of nearly 20% in the first day, okay? And then the next 6 days, you have another 25 to 30% mortality, and a little more out to day 30. And if you live 30 days with a type A dissection unoperated, you're one tough dude, and you might survive it. But that early hyperacute period is why we want to get our surgeons to wake up in the middle of the night and come in, because you're a ticking time bomb. You might look perfectly fine, and then it ruptures, right? Have any of you ever been to Yellowstone Park? Oh, good. Have you seen Old Faithful? Old Faithful is the most famous geyser in the world. Well, Old Faithful has something called a pre-eruption, where the water shoots up about 15 feet. And what that tells you is the big eruption is coming, right? If a patient with dissection gets to your hospital with the pre-eruption, you don't know when the big eruption is going to occur. And if it happens, you may not have time to help that patient. Demographically, most patients have had hypertension, Marfan syndrome, 4%. The learning point here, especially for the fellows, is prior heart surgery is a risk factor for aortic dissection, and it's often unrecognized. Okay? Why? Well, they may have had an aortic valve replaced, and the aorta was weakened, or it was a bicuspid valve, or they had a cabbage, and a vein graft was taken and plugged into the proximal aorta, and the aorta was weakened. But prior heart surgery is a risk factor for dissection. Family history, of course, 10%. Cardiologists and cardiac surgeons cause dissection. I caused one with a wire when I was a fellow. I put the wire in the groin. I thought it went right to the right coronary artery. Turns out it was in the media of the aorta. Probably a diseased media at that, but we immediately called cardiac surgery, and my faculty mentor in the cath lab had a few choice words for me. And I went into non-invasive cardiology. So the challenge we have with dissection is that it's so rare, right? Here's 40,000 patients coming to an emergency department, and over here on the left, only 0.3% have dissection. Heart attacks are, way more common, 100, 200 times. Pulmonary emboli, way more common. Obviously, pleuritis and reflux, way more common. And so we don't think of it. And because we don't, we miss it a lot. This is take-home message number 2. Dr. Paul Dudley White, in his single-author textbook, wrote, "Pain attending the splitting of the aortic wall in the thorax or back comes suddenly at its maximum." Patients have a photographic memory of what happened. It's different than a heart attack. It's different than indigestion. This is a moment, and some of them fall to the ground. And if you get them secondhand and you don't ask them, "Oh, by the way, how did it start?" You lack the most important historical clue that they had. They remember, I was gesturing with my left hand, and it happened. And it's usually the most intense pain they've ever had. And disarmingly, not infrequently, it goes away. And then you think, oh, they're fine. Pain went away. Must be fine. No. Listen. Tick, tick, tick. Very interesting. And this is by far the most common pain characteristic. 82% of patients have it. Most of the rest have fainted. Take-home message number 3, unexplained syncope. Think of dissection and PE. Don't forget those because they're lethal. You send them out and they come back in a box. So abrupt onset of pain is so important, much more common than sharp or tearing, the things that people like Kim Eagle have written textbooks about. The abrupt onset is where it's at. I'm happy to say the physical exam is still useful in this era. A murmur of AI is present in a quarter of type A, and sometimes a systolic murmur is present because the valve has been disrupted by the dissection process. You may not hear AI, but you hear a new systolic murmur. And you think, oh, that's never been reported. It's not in Kevin Harris's notes. He listens to the heart. And pulse deficits are very important too. If you find those, look out. That's really important. So if you look at high-risk conditions on the left, Marfan, family history, known aortic valve disease, recent aortic manipulation, known aneurysm, those are high-risk conditions. In the middle is high-risk pain features we talked about, particularly abrupt onset. And then the right hand, high-risk exam features like a pulse deficit or a murmur of AI or hypotension. If you ask the question, how many patients with dissection have one or more of those? The answer is over 90%. Only 9% have none of them. What this tells me is that we could probably diagnose up to 90% of the patients in the ED. And currently it's thought that at least half are missed. Half of them are missed. And half of those have a big mediastinum on X-ray. So I think we could do a much better job if we just used a simple clinical risk profile. And then we'll talk in a minute about the use of imaging and biomarkers. The chest X-ray is normal in a third. Holy cow. The aorta's ripped and the chest X-ray is normal? How can that be? I'll tell you in a sec. And this is a big problem for cardiologists, right? There's a lot of people walking the earth who have big aortas. They fill my practice. I get a referral a week, an aorta that's 4.1, and I don't know what to do with it. I know it's bigger than it should be, but is it diseased or just larger than it should be? I don't know. This is a disturbing slide. In IRAD, we showed that if you look at type A dissection presenting, we use this surgical cut point of 5.5 centimeters to decide when to repair an ascending aorta. 59% of type A dissections come in with an aorta that is smaller than that. And not a small number are normal, right? They're not aneurysmal. And this, I try to get you out of this mindset that it has to be aneurysmal to dissect. It's not true. An aorta can dissect that's normal in its diameter, but it's not normal in its mechanics. That's alarming and so true. And there are families who dissect normal-sized aortas, period. They're not aneurysms, but they tear. And I'm gonna go by this slide. We're getting better. This is IRAD data over the years, and what was true in the 90s and early 2000s was that 25% of type A's passed, and the number of patients denied surgery was around 12%. That number's gotten better and better. So the in-hospital mortality is now around to 15%. And if you look at patients that are operated, at good places, it's 13% or less. Our operative mortality for type A is under 10%. I'm sure yours is now too, because you have great surgeons here. If you have malperfusion, obviously you do worse. This is a study looking at different types of complications: coronary malperfusion, coma, neurologic deficit, visceral malperfusion. Patients do worse, and the more malperfused organs you have, the worse you do. Obviously, this makes a lot of sense. So malperfusion is a big challenge for us. For type B, uncomplicated, those are patients that haven't ruptured, they have no malperfusion, no high-risk features. And you see the high-risk group there. And that's the group we're thinking about, okay, should we or should we not provide an endovascular therapy? This has been studied. The INSTEAD study looked at the question of patients with type B. Should they get a TVAR or not compared to optical medical therapy? And at 2 years, the survival curves crossed, and it looked like TVAR was helpful. And it is an example of something that your vascular surgeons do all the time, and it can be very helpful in patients. What happens if you do that is that the false lumen gets smaller and the true lumen gets larger because the graft pushes the false lumen out of the way. And presumably, that allows the aorta to have less chance to grow. Our aorta is held together by the media. That's the elastic elements in our aorta. And when the media tears in a dissection, you don't know how much of the tensile strength is buttressing the false lumen. You just don't know. And it may grow. We talked last night about a patient who grew a matter of weeks to 7 centimeters. That can happen. It depends on how much elastic strength is in that false lumen. In the IRAD registry, we've looked at this, and it looks like over 5 years, those getting endovascular therapy did better, but it's not randomized. And there are 3, I'm happy to say there are 3 large trials being done right now. Improve AD is in this country, Sunday in Denmark, and Earnest in the UK. And within 5 years, we should have an answer whether we should provide endovascular therapy for stable type B dissection. If you're unstable, we're going to go ahead and typically offer that to reduce the risk of further malperfusion or rupture. Okay? Here's an example of a lovely endovascular graft for a patient with type B. So how do we follow these patients? Obviously, we treat them medically, we watch them, and we give them education. And here's the challenge. Over 12 years, if you've had an operated type A, there's about a 40% chance that you're going to either pass or have another intervention needed. This is why we have to follow them. And there's a little bump in that first year for the patients that have a really weak aortic wall. So we have to watch these patients really carefully. And if you send a patient back to Oshkosh without them truly understanding you can't run out of your medicines, you must have your imaging, you must call if there's a new pain syndrome, we've done a disservice to them. And this happens all the time at our place and probably at yours. You have a whole group of people that save a life, and then they go back somewhere where they may or may not get medical care. And it's really it's a problem. If they have a patent false lumen after type A, they do worse. If the entry site in a type B is large, they do worse, more than 1 centimeter. If the diameter is bigger in a type B, they do worse. Bigger tear, bigger aortic diameter, they do worse. Medical therapy is largely built on studies of people with genetic disease, Marfan syndrome being the most common. And so over the years, we've learned that both beta blockers and angiotensin receptor blockers are useful for retarding growth in a Marfan aorta. And the combination appears to be a little better than either agent alone. So I try to get my patients on effective doses of those 2 classes of drugs. We translate that to all aortic disease. I'm not sure it's accurate, but that seems to be what we do. That's what Kim Eagle does. So either a beta blocker or an ARB, and probably both are a little better. So managing blood pressure is critical. This study looked at patients who had a type A repaired and how well their blood pressure control was. Look at that survival difference, nearly 50%. If their blood pressure wasn't excellent, they did a lot worse. And I don't know if you've tried to manage blood pressure lately, but it's hard. It's really hard. And the most common cause of a patient with a high blood pressure in my office, and the second, third, and fourth, are they're not taking their meds. So if I'm not there in the morning to give them their little pill cup, and there's 5 pills, look out. So we need to do a better job at that. Now, there are a couple of interesting drugs that affect aortic biology that you should know about. One of them is calcium channel blockers in Marfan syndrome. If you take Marfan mice and feed them calcium blockers, their aortas blow up. We study this in humans, and that it is a signal in Marfan syndrome, unoperated ascending Marfan syndrome, that calcium blockers may hasten aortic growth. So I recommend that against that. The fluoroquinolones, which are my favorite antibiotics, cause tendon rupture, and they may affect aortic wall biology in a similar way, connective tissue. So patients who have aneurysms, we would like them to avoid this class of antibiotics if we can. And this is the calcium channel blocker stuff from the GENTAC registry, where we looked at the hazard ratio of patients who had Marfan and unoperated ascending, and they had about a doubling risk of aortic dissection and aortic surgery. And here's data looking at the fluoroquinolones, several large studies suggesting about a 1.5 to 2-fold higher risk of an aortic problem compared to other antibiotics if you take fluoroquinolones. All right, so long-term, we're going to manage their DPDT with beta blockers. Additional antihypertensives, I'm going to use an ARB. Heart rate goal, 50 to 60. Blood pressure goal is your strictest in all the world. It's under 120, right? We typically tell patients to avoid heavy lifting. What do I mean? It's when you do isometric exercise, when you crunch down and lift, you can pop your systolic pressure 100 points. That's hard on a diseased aorta. So if they're going to strain, I ask them not to do that. Is there a number? I don't know a number. I typically say 40 pounds. Why? Because we asked 60 IRAD investigators what number they used, and it was from 10 to 80. And the median was 40. So Kim Eagle chose the median among 60 crazy cardiovascular specialists interested in aortic disease. Obviously, occupational things that involve heavy lifting, you gotta try to help them find a strategy, right? And then imaging. And because of that early growth after dissection, even repair, we want to image typically at 1 to 2 months, and again, say at 3 to 6 months, and then annually after that. Okay, so I want to get to the future, and let's talk about what I hope will be more precise care. Some of this is in the beginning, some of it is now here. Genetics, imaging, biomarkers, survivorship. So you're all familiar with genetic aortic conditions. These are the first that we had identified: Marfan syndrome, Loeys-Dietz, Ehlers-Danlos, and Turner syndrome. Genetic disorders that can cause aortopathy, dissection, and rupture. Wow, how far we've come. Now we understand that HTAD, heritable thoracic aortic disease, comes in different flavors. Some of the genes involve the extracellular matrix. Some involve TGF-beta signaling. Some involve smooth muscle cells. And they affect families. And they cause devastation in families. If you look at the Montalcino Collaborative, which is studying genetic disorders non-Marfan, the ACTA2 mutation, which killed John Ritter, is the most common, 30%. TGF-beta BR1 and 2, 14 to 25%. SMAD3 is another one. So we're beginning to get a library of genetic disorders that cause familial aortopathy. And increasingly now then, we will have a way of checking a person with a familial tendency to see if they have it. And increasingly, it can help drive their therapy, but also screening first-degree relatives. So a patient who has an inherited aortopathy must screen first-degree relatives. Their kids might have it. Their parents might have it. And they don't know. We looked at 355 patients in our place that had a dissection when they were young, and they didn't have any other markers of genetic diseases, and 10% of them had a inherited condition. And interestingly, half of them were the Marfan gene. So patients who have Marfan syndrome may not look like they have Marfan syndrome, but their aorta might. There are studies of twins, same house, same gene. One of them is tall and lanky and has typical features, another one doesn't. So the degree to which genetic disorders penetrate into the phenotype varies a lot. So we have to really be on guard for this. And some of these are just disarmingly complicated. Here's another study of 240 patients with genetic variants in aortic disease, and about, again, 10% had a dissection. The FBN1, again, that's the Marfan gene. They don't look Marfanoid, but they have it. The other thing you have to realize, of course, when we send a patient for a genetic test, It's not black or white. If they have the gene, sure, you've got it. If you don't, okay, great. But there's things called variants of unknown significance, where it's an abnormality close to a known gene. Those are 3 times more common than having a pathologic hit. So if I send Josh for genetic screening, I'm going to tell him, if there's a chance that we're going to find something that we don't understand. And we're going to have to live with that. And over time, there is a website where we can go to see if that moves from unknown significance into pathogenic, but we're going to live with uncertainty. And some patients say, you know what, I think I'll opt out. Don't think I want that. A long-lost great-grandfather had an unexplained death, and was that a dissection? Should I screen this person? Maybe not. And now we have the ability, using the genetic signals that we have, and whether there's a family history of dissection at a young age and or small size, and or is there growth, we can start being much more precise with when we offer surgery, which is a huge advance, right? This gene up here, PRKG1, we're replacing normal aortas in those families if there's a family history of dissection at young age. I sent a 26-year-old to have her aorta replaced because her mother dropped dead at 33 of a dissection. So I'm happy to say the gift of genetics is coming. It's still very complicated, but it's coming. And so, for sporadic dissection, we still use 5.5, or if it's growing. For non-symptomatic HTAD, it's going to be at 5, unless there's another feature. For Marfan, it's 5, but 4.5 if they're growing or they have iris features. Loeys-Dietz varies a lot. There's a bunch of genes under the Loeys-Dietz category. Bicuspid valve aortas don't tend to dissect unless they're growing or there's a family history. And if they're growing, I suggest you check them for another gene. It's actually rare for our bicuspid aortic valve aortas to grow. And when I see one growing, I'm screening them for other genetic aortopathies. And a lot of the ones that dissect, I think, had another hit, actually. So the likelihood of finding a gene, if there's syndromic features, it's 90%, family history 30, dissection at a young age 10. Whoa, you mean I can have a perfectly classic Marfan patient who has a negative screen? Yes. It might be a duplication. It might be a deletion. It might be buried. So our genetic testing is not perfect. Not perfect. So when to perform, I think syndromic features, age under 60 with dissection, family history of aortic peripheral or intracranial aneurysm, and a family history of sudden death less than 50. This is important for our fellows. When you see a patient with an aorta 4.5, you ask the question, is there a family history of aortic disease? And they say no. And they say, is there a family history of unexplained sudden death? And say, oh yeah, 2 of my uncles died at 45. Could have been dissection. The autopsy wasn't done. They put, quote, natural causes. There is no natural cause for death at 45, by the way. I don't believe that, right? Okay, so bicuspid aortic valve, higher chance of aortopathy. So if you find it, you want to check the aorta, and you want to screen the relatives, first-degree relatives. So if Chris has a bicuspid valve, even if her aorta is perfect, I'm going to screen her aorta, but I'm also going to screen her first-degree relatives. And failure to do so is a travesty. We have to do this. One of our faculty members called me one day and said, Kim, I can't believe it. I said, what? I have bicuspid valve, large aorta. I said, I know. I said, my brother is a stockbroker in Chicago. He dropped dead today. He wouldn't get screened. He had a 7-centimeter aneurysm at post. Totally preventable. Totally preventable. Okay, I'm moving quickly here. This looks at this question. How well are we doing as a system for monitoring aortic growth. And this study shows that patients are not getting guideline-directed imaging. That curve on the left shows you that at 6 years, less than 5% have had an imaging protocol that you and I would say is guideline-based. They get lost in our system, which is terrible. And the ones who get lost are the ones who die. If you follow them, I mean, you can count on one hand the number of failures of current therapy that we have. We do a great job. If they show up and take their drugs and get imaged, they should have a near normal lifespan, and the Marfan population does now. But if they get lost, they die. So searching for a biomarker, there's all kinds of targets, right? Wouldn't it be great if we just had a troponin for the aorta? I'd love that. We have endothelium, the elastin, vascular smooth muscle, and regulatory proteins, smooth muscle. So what about inflammation, elastic fibers? Thankfully, we do have a biomarker, and it's really sensitive, and it's D-dimer. When you dissect your aorta, you initiate clotting cascade in your body that elevates D-dimer probably 98% of the time. The study we did in dissection, you look on the left, patients who came in the first 6 hours, their D-dimers were off the charts. The challenge with D-dimers is not specific, right? It can be elevated if you have a PE. It can be elevated if you have a big MI and there's clot in your ventricle, or if you have DVT. But it is highly sensitive. We should be doing it more. We are now trying to routinely measure D-dimer for patients who come in with acute thoracic pain. And I think it can guide when we image. I've only seen personally 2 patients who had an acute aortic syndrome without an elevated D-dimer. They both had small intramural hematomas in the arch. So I don't know if you use D-dimer much, but I really believe in it. I'm going to go by this. Okay. So we need to move forward and get better with imaging. You think about all the data that's on a CT scan, how much of it do we use? You're like, what? Crazy. So we know that what happens to the false lumen matters. This is a study we published many years ago from IRAD, and we showed that if you had a completely patent false channel in the type B and you thrombosed part of it, you probably thrombosed the reentry tears, and that aorta could grow up high where that tear was. You create a blind loop up there and increase mortality if you go from completely patent false channel to partially thrombosed, because the place the blood could come back is blocked, and now it's just swirling up there. Here's an example of a patient that I took care of, a physician who, on the left, was, 53, and about a year later had grown 4 millimeters as he thrombosed part of his false channel. How the blood flows in and out in a type B and the tear is really interesting. This looks at something measuring ejection fraction of how much blood goes back into the false channel and then comes out. And it turns out the higher the ejection fraction in your false channel, the higher the risk, because that distal is stiff and it's going to break. Or how big is your aorta in length? If your aorta starts to get kind of squiggly with time, that's an aorta that's diseased, more likely to dissect. Same thing with your carotid arteries. If you have a syndrome and your carotid arteries look like a road map along Route 1, California, look out, higher risk. We don't use any of this information, but it's known. How about doing 3D MRI in your aorta? What about that? Looking at flow. This looks at helicity within your aorta. This looks like beautiful laminar flow in a patient with a tricuspid aortic valve. And this is a tornado in the ascending aorta of somebody with a bicuspid aortic valve. And it turns out how much laminar flow we have predicts how we'll do over time. If we have a lot of helical flow creating forces against the aortic wall, where's the outcome? That type of dynamic imaging we just don't do very much, but helicity matters. False lumens expand the more helical flow, non-laminar flow we have, right? Or vascular deformation mapping. I really like this for the future. This looks at taking a CT and really looking at it segment by segment. Here's a patient who had elevated growth in Marfan with a type B dissection. And we see that patients who dissect, they have growth. It's often radial. And if we look more closely, this slide shows you that when you actually look at where the aorta is changing, that's not total diameter. That's actually looking at a little segment in a cross-sectional view as a possible predictor of, okay, that's a segment that's at risk. And I think in the future, we may well be using vascular deformation mapping to decide, okay, yeah, you probably should have a stent graft. That's like a hot spot. And this has been seen with patients who've had prior ascending repair. Another example. And finally, let me finish with survival. I have gone through the slides, holy cow. We're doing a terrible job with survivorship. If you ask patients a year after the dissection, how they doing? 39% are disabled. 70% stopped having sex forever because they're afraid. A third are depressed or anxious. And almost 3/4 say, I need better information from the people at the Minneapolis Heart Institute on what I can do. We save their life, but we don't help them survive. And this is something that I'm really committed to, and we're working on it with the Marfan Foundation. I don't want my patients to survive. I want them to thrive. And to thrive, they have to have information. Okay? So if you said, what are the top concerns? Patients say, having the right educational resources. Does genetic testing actually improve my health? What kind of exercise can I do? For subacute dissection, when should I have surgery, if ever? What meds are best? These are common questions that we don't answer. And if we do, sometimes it's in the context of a 5-day admission where they're in the ICU. They forgot everything. It's a blur. Their family's just been worried about survival. So everything we tell them goes in and out, and they leave with uncertainty, and they're afraid to ask. So this is why Kim Eagle and Kevin and Josh at our clinic visits, we hammer away. How you doing? Sex is safe. Do you understand your meds? How's work? Do you understand what type of exercise I think is helpful and harmful? If we don't ask these questions, we're really turning our back on a very important part of what we're trying to do here. I'm happy to say the Marfan website has great resources for your patients. They're in lay language with lots of illustrations. And just think of it. The first publication of dissection was in 1760, King George II. Apparently, he went to the bathroom in the morning after he had his chocolate. And there was a sound, and his valet de chambre went in to find him dead. And he had a pint of coagulated blood around his pericardium. I've been studying aortic dissection for 42 years. And I feel like we're just beginning, right? I kind of feel like we're Neanderthal still. But I love working with institutions like yours and people like Kevin. You know, we're fueled by passion for a disorder that is rare but absolutely lethal. and people live in fear. And we can do better, and we're working on it. Charcot said, disease is very old, nothing about it's changed. It's we who change, as we're willing to recognize what was formerly imperceptible. And we're still doing that. The IRAD investigators, what can I say? There's 62 centers currently, more coming. Half of them pay us some money to participate. What? You mean there's no grant for that? No, it's a reverse grant. They pay our core lab money to be part of it. Why? They're fascinated by it. And they want to be part of a team that's trying to push the boundaries. And that's what wonderful science is, isn't it? People like you and I saying, we're not there yet. We can get better. We're going to get better. These are the people at my own place that are so amazing. We have a great, great aortic team. And Oser said it best, no disease more conducive to clinical humility, an aneurysm or dissection of the aorta. I'd like to thank my mentors and my supporters. I've been in a strange personal journey throughout my life. My wife has dementia. She's in a long-term care facility. And curiously enough, life brings things full circle. And I'm just living large and loving being here today and talking to you about one of my favorite things. Thank you. Yes, sir.
Thanks for that terrific talk. It seems like 10% of the people I see in clinic have mild enlargement of their ascending aorta. And so say a typical person has like a 4.1 ascending or enlarged aorta, no family history, and is normotensive. How often do you image those people? What should we do?
Yeah.
Should we put them on, statins and ARBs or ACE inhibitors, even if their blood pressure is okay, or a beta blocker? What's your thoughts?
It's a really common question. It's an important question. I think if they're between 4 and 4.5 and they have no syndrome, I'll image them at a year. And then after that, every other year, I'll want to have a good blood pressure. And, I'll be targeting 120 if I can. If they've got an aorta that's more than 95% confidence limits, I don't know if they have a disease or not. I will instruct them on things like, the antibiotics I talked about. I will definitely want to make sure their blood pressure is controlled based on home readings. I probably will give them lifting instructions. I'll tell them, I don't know if you just have a big aorta or if this is actually a diseased aorta. And we won't know. Most of the time it's nothing. But I will image them probably every couple of years.
Would you alternate like CT and echo, or if you're...
So I think that if you can see the aorta that's enlarged well on echo, and you've done a complete body scan with MRI or CT to see that the rest of the aorta is perfectly normal, then I probably would just do the echo.
Okay.
And avoid the dye.
Thanks.
Yeah. Yes, sir.
Thank you so much. That was a very wonderful talk. 3 brief questions. The first one is, since your involvement in the guidelines and specifically the aortic dissection and aneurysm and dilatation, what do you think is the one thing that helps clinician adhere to guidelines and follow the guidelines? Number 2, how do you deal with the borderline cases? Like if the cutoff is at 5 and then bicuspid aortic valve is 4.9, things of that nature. The third is if you could explain a little bit more about, I'm fascinated by the pacemaker reuse program that you are one of the, originally I'm from Ethiopia.
Okay. I didn't understand your first question. You were bold to ask 3 in a row of somebody my age. That's a lot to handle, right? So give me your first question, and then we'll go.
My first question is, what is the best way to make sure clinicians follow guidelines? You are one of the big people in the guidelines and coming up with guidelines. What, in your experience, what is the best way to make sure people follow guidelines?
Okay. So I think that by far the best way is to create the key points of guidelines and try to embed them in the care. Systematize knowledge that we would like to try to follow every time. That's hard to do, and we're bombarded by pop-up messages in our EMR and our email and so on. So the more we can embed the most important parts, there was just alert, Kevin, this patient had an aorta that was 4.1 on a calcium score, right? Ironically, we have the chance to find most aortopathies in our country by screening them for coronary disease, which we should be doing. We should be doing calcium scores on anybody who's probably 50. We have a chance to find all these patients. Then they're going to go to his clinic, and he's going to have 2,500 more patients with a 4.1, and we will have to deal with the uncertainty. But we'll find the big ones, and some of those, you know, I can't believe the number of aortopathy patients I found with calcium scores, and three lung cancers that were cured. So curiously enough, there's a test that might be useful. Anyway, systematize wherever possible. Your second question was if they're close. So then you're thinking family history. Anybody dissect small, anybody dissect, anybody drop dead? Is it growing? How do they feel about it? And do you have an aortic surgeon that's a superstar? Right? If they're growing and they're getting close, I may say, you know what? I'm a little uncomfortable waiting now. You've gone from 4.2 to 4.9 in 5 years. Each year hasn't been big growth, but the constellation is you're growing toward a surgical cut point. I have a great aortic surgeon right here. She'll do you tomorrow, right? Let's remove that. That's what I do. We've been working, Project My Heart, Your Heart is recycling pacemakers in the third world. And we are working in a number of countries now. And if you want to learn more about it, just email me. It's a labor of love. We just finished a randomized trial where we took 300 patients in 7 nations and randomized half to a used pacemaker we reprocessed and half to new. And the used ones that we've created are perfectly fine. So I hope this will be a reality in the future. Now we're going to work on defibrillators next. Yeah, thank you. I'll pay you $500 for that, by the way. Yeah, sure.
I have a question about when you imaging, what age? I mean, obviously it's related to the comorbidities, but if you have an individual that doesn't have a lot of limitations, is there an age at which you say, you know, I think we're going to stop looking now?
So that's a really good question. And I think it relates to the fact is there an age where you and the patient decided we're not going to do anything no matter what? Yeah, I take care of this guy. He's now 80. We followed his aorta. He's been afraid of surgery for 25 years. His aorta is 58. We offered him surgery 10 years ago. And I said to him, you know, last visit, I said, you know, why don't we just stop looking? He said, oh, no, I want to keep looking. And I said, is there a size at which you might pull the trigger? He said, well, not yet, but I might change my mind. I don't know what to do, you know? And he calls me and said, I want to make sure I get that image 2 weeks before our visit. I said, oh, okay, Stanley, it's fine. That's fine. Other questions or beefs? Yes, sir.
Every time we send our pathology, we don't really get much results from, or we don't really see much difference, say inflammation in specific. And thank you, because we all the 40 millimeter aortas that we do bypasses on, if there's a benefit of taking a sample of that, if there a predictor factor from the histology that we can say that this will be more predictive to enlarge to dissect afterwards, since we have the opportunity of take.
I don't know. I mean, I think if we don't look, we'll never learn, right? But I don't, you know, I don't know. I have to ask Joe Caselli that question, if he's routinely doing aortic biopsy in patients who get a cabbage. I don't know. The cost of doing it, obviously, is enormous. You'd have to do thousands of samples, and you'd have to do omics of every type at great expense. And you might find a hit, but it would take a lot of money. right now the NIH isn't really funding a lot of fishing expeditions, right? You've got to have a known whale that you can hook to have even a chance for a grant. Did somebody else have a? Yes, hi.
Two questions online. First one is from Dr. Nick Burke. How do you treat and follow aortic root enlargement?
So I'm gonna use the same numbers with aortic root enlargement, right? We're watching for growth. We're watching that aortic valve. We're thinking that's a patient who might have a genetic disorder. So you know, aortic root, aortic ascending. I'm gonna treat them the same, for sure.
Thank you. The second question is from Dr. David Lynn. What's considered clinically significant aorta size or area change on CT or MRI? Do we compare to most recent scan or images from 5 years ago?
Yeah, that's a great question. So, you know, we talk about 3 millimeter growth in 2 successive years or 0.5 millimeter growth in a year. But I think that the total growth picture matters. And I mentioned that example of a patient who's gone from 4.2 to 4.9 over a period of 6 years, and that's on great therapy. So I know the blood pressure is 115, and his aorta is growing. So I'm gonna pay attention to that, and I know that there's an inflection point of dissection risk at 5. There's a much bigger one at 5.5, and it's almost vertical at 6. So I'm gonna start to say, you know what, I'll at least introduce you to my favorite aortic surgeon at 4.9, and they may suggest you have surgery, and if they do, I'll go with that, because I want to prevent a catastrophic outcome. Kevin, did you have a question?
I do.
Oh, good.
Fantastic talk.
Oh,
Thanks so
thank you.
much. So, and we have some of our surgeons here. If a patient is discovered, as often is the case, a patient's discovered 5 days after or 4 days after their onset of symptoms, do you believe that patient is, and you're discovering it late at night, do you believe that patient is more stable? And does it matter if it's a classic dissection or intramural hematoma?
Well, the longer you've lived with the problem, Darwin says the longer you're going to live. Right? Did I just say that? Yeah. Like, okay. So we don't know what young people are going to do. They're unpredictable. So I'm more worried about a modestly enlarged aorta in a young person than I am in somebody who's 60 years old, where at least history tells me they've lived with a problem for a while and it hasn't killed them yet, right? You know, it's sort of in the preoperative screening world, pre-op. You know, I say to people, you know, if you live to be 80 years old and your heart has never told you there's a problem, it probably is not going to tell you a problem around gallbladder surgery, where you go home the same day. So why are we inventing a whole routine for that? I'm gonna die. That's a diatribe, I'm sorry. So the older they are, the more comfortable I feel with the possibility that their disease is not kind of, you know, neoplastic, okay? You probably feel the same. Yes?
I think there's a role for genetic testing, spontaneous coronary
So I think if you do a complete history and physical and family history and look for evidence of some sort of an arteriopathy, because that's a rare thing, right? So they might have FMD, they could have Ehlers-Danlos. So younger people who dissect arteries, I screen them. And I don't know what they might have, but something that unusual, yeah, absolutely. Yeah, I would. And some of those disorders we're screening Loeys-Dietz, we're looking at the head in all of them because they can have cerebral aneurysms too. So there's increasingly a known connection between certain gene profiles and both aortopathy and other arteriopathies. And when you do that one CAT scan, you may find stuff, right? I have a patient who has an aorta of 5.6. He doesn't want surgery, but I knew he had a splenic aneurysm. And he called me from a hospital in California and said, listen, I developed acute left upper quadrant pain this morning. What should I do? I said, call an ambulance. Let him know that you might have had a splenic artery rupture. And he did. That probably saved his life because we saw that and alerted him to it, and I knew it, you know. So I really thank you for the question, because we tend not to think about the branches, and they can tell us stuff too. And Shane Morris has shown that you know, when your carotids are, you know, really odd in their windiness, the much higher risk of aortic dissection if you have this tortuosity in your carotid arteries. Well, once again, I have great respect for the institution. Really a pleasure to come. Thank you, Josh and Kevin, for inviting me, and had a lovely dinner last night, and look forward to the next time. Thank you.